This session was recorded on the 21st of July 2022 as part of the National Cancer Patient Experience Survey 2021.
I'm Irina, I'm head of nursing for cancer at King's College Hospital across our 5 sites, and Sola is our quality improvement lead who helping me to deliver improvements for cancer patient experience survey, and we do use cancer patient experience survey as a main lever to drive quality improvement work at King's College Hospital, and just what we're showing you is one of the examples. So we took a challenge to improve question 7 in an old survey, explanation of diagnostic test result in completely understandable way. We choose breast adult cancer population because it is a tumor group that we're fully responsible for at King's, because we are cancer center for some tumor site and we are DGH function for another. For breast we are DGH, therefore we completely oversee that pathway. So we focus on breast, but we moved into understanding actually what our ethnically diverse community is at Camberwell and at Bromley area. If we go to next slide. So we first of all ask national team if they could show us is the difference between our white population and ethnic diverse population, and you could see in this particular question scores really differ largely here and statistically significant. So that was very interesting. So what we saw, okay, can we look more and more at the data we have in the trust? So what we task ourselves is understand what actually ethnicity, and it wasn't readily available to us. We reach out to outcomes team and a trust who were very helpful, who were able to analyze the data through our systems to have a breakdown of 1 year diagnosis by ethnic group, as you can see in a table here. Now we know, okay, that is our population. Okay, let's have a look for that year. What was a pathway of care looking like from a diagnostic perspective, referral from diagnosis from GP to actually being diagnosed? And what we found for this cohort of patients, that our Black and African population and Asian population had a shorter diagnostic pathway than white counterparts. And that was interesting data, and it's almost turning point to present to our clinical teams, because now we have a data which really shows that actually we're doing so well, we're doing better in this population than in the white, but why then our ethnic population, the diverse population, is so unhappy or dissatisfied with the care, which obviously created quite a lot of curiosity for clinical teams to find out and really help an engagement. We have reached out to the ladies and we recruited 2 absolutely amazing patient representatives without whom we couldn't really drive and do this work. Sometimes they were driving us, I think, which was amazing because they were really dedicated to improve what we're doing. We reach out to the population at Prue and then McHill to try to understand the experience of care at the time of diagnosis, and we somewhat deviated from actual question. We have kind of had this challenge. We went back to national team and saying that actually when we heard from our ladies, 89% of them only was giving good comments, and they actually could name every test under the sun. However, we wasn't getting a case, so what can we improve? So we understood we're probably not approaching this correctly. We went back, done a focus group where we focus more what was your experience around diagnostic tests, and that is when we got real information. Because what we heard from 11% of our ladies is actually how they've been explained something or how they've been treated. That would influence the experience of understanding or accepting diagnostic tests or diagnostic pathway. And therefore, we changed our question A to reflect our ethnic background, but B to actually capture experiences that people have when they are coming to one-stop diagnostic clinic. We thought that what we heard and story we heard was so powerful that we needed to do we needed to do a presentation, or we needed to capture this in some other way. So we come up with an idea to do a video to capture patient voice. And we would like to share this video with you today. And while Sola is presenting this one or trying to get that up, what I would like to really invite you to, when you listen to ladies speaking there, to actually explain how patient experience and how understanding cultural diversity has a direct link with clinical outcomes. Thank you very much for watching a film. I think that the patient voice is powerful enough. And just to say that after we were able to share this with our clinical teams, they were quite ready to look at the changes. So if we go to slide before that. So changes that we suggested and we're piloting are changes that actually been proposed by our patients. They come up with a breast care flowchart for diagnostic testing. They felt if they would have something really simple to explain to them what to expect on a day, will really help them to prepare for the clinic. And the more we work with ladies, the more they understood that a part of this being cancer, they never told that there is more percentage of this not being cancer. Therefore, having up-to-date and correct information and right information in many areas, written information in electronic form on our website, it's really important, and some posting is really important, and we work with them to see how we can do this. Therefore, we have updated breast care unit web pages. We checked the traffic, which was really high. We checked that there is a translation to 70 old languages, and when flowchart or other information is translated, it's actually readable. We start work with our transformation team, and we updated to 8-week letter, and it is on our system EIS, which reflect all the changes our breast lady wanted. We're working on consistent presence of CNSs at 2-week clinic, which name will change, as you know, or one-stop clinic. And that is because our ladies said that they were most important people when they were told of possible diagnosis to get the support early and a point of contact early. And obviously, we're now working on a staff training video based on what you've seen, because we understood from clinical feedback, clinician feedback, that video was so powerful that actually they want other staff to see it and to start understand how our awareness of cultural differences can lead to different clinical outcomes. And I let Sola to present the rest of the slide.
So myself and Irina have brainstormed with our project group and come up with some top tips, and it's sort of our learnings from doing this project, but it's also, I guess, our advice to anybody who's looking to take on a similar type of project aimed at addressing health inequalities. So the first learning for us was making sure that we got the backing from our trust executive leadership and our internal and external partners. So we have the backing of our chief executive for one of our hospital sites, who's also the executive lead for cancer. Getting the right people around the table. So we met as a project group weekly. We've been doing so since sort of July last year. And we have two fantastic patient representatives or lived experience partners, our clinical nurse specialists at both of our main hospital sites, our cancer clinical lead, reps from our comms team, patient engagement and experience, our South East London Cancer Alliance, our radiology colleagues, and our equality and diversity team. So that's the wider group. We have a core group of people who meet every week, but we make sure that everybody is also included into every bit of correspondence that's developed and all of the documentation that we've produced, so that everybody gets a chance to see it and everybody gets a chance to contribute. So the third piece of learning is really understanding what our cancer patient experience results are telling us. And Irina's talked you through sort of how we did the analysis in the early stages, but it's really understanding what the year-on-year variation looks like. Are we getting better? Are we getting worse? How can we break it down? Can you break it down by age, breaking it down by ethnicity? Because obviously BME is a very large group and it's not a homogenous group. So we then have to do a bit of a deep dive within that to understand what particular groups of patients are telling us. And also reviewing our population demographics, and that was really key in working with our South East London Cancer Alliance to understand what our wider population of patients looks like, working with our patient advice and liaison team to understand what data they're able to sharing us, and also using any available data we're able to get hold of, really. Wider team engagement. So this was really important in the early stages. We've had engagement events with our breast care teams at both of our hospital sites. We've had meetings with surgeons in those groups, our cancer support workers, our radiology colleagues, and all of the admin staff that work in that group, to update them on what we were doing and to make sure we kind of had their buy-in, but also to share with them what some of the suggested change ideas were at the time. And they were just really impressed, that we'd taken the time to reach out to them, but also that we'd invited them to feed in on our work. And they had a lot to add. And they are a really vocal group, and I think that's really important to go beyond just the staff on our project groups. The next tip is really listening to your patients. So we spoke to in total about 30 patients, and we did a series of one-to-one interviews, and we did a focus group at the end as well. And through that, we've got some really rich data, and obviously we've got a couple of patient reps on the project group, but speaking to the wider group of patients about their concerns, and basically they had a lot to contribute, and we were just grateful for their feedback, and also sharing the feedback with them at the end as well. So once we'd come up with the change ideas, we then went back to the same group of patients to say, this is the output of the work that you've helped us to develop. And again, we shared the video with them, we shared the updated 2-week wait referral letter, we shared with them the breast care flowchart, and they were so impressed with the work. And I think they were quite thankful that we took the time to come back to them and share the outputs with them. And I think lastly, be flexible and responsive. So the initial ask for us was that we address the discrepancies between the understanding of our white population and our Black and minority ethnic population as part of question 7. But what we learned by speaking to our patients was actually that wasn't something that they needed to be explained. It wasn't necessarily, I mean, they understood all of the tests and could name all of the tests, when we were speaking to them. But what they did say is that there were other areas of concern and other areas that we could improve on. So we were just flexible enough to be able to pivot slightly and focus on additional areas. And I think that's pretty much it. Irina, have I missed anything?
No, I think that we really believe we gave a platform for patients and staff to collaborate together and come up with something that everybody feels proud of and good and able to advocate. I think that patients volunteering, they want to pilot the chat for us because they feel that part of that work, yes. And obviously work continues and quality improvement continues. We still need to go to next phase, and we still need to evaluate, and hopefully in a year time we will change the practice. We presented this at our alliance level as well, and they interested to see after first pilot of implementation what results we have, and if results are good, some other breast teams in our alliance would like to try some of the change ideas that were suggested. Thank you very much.
Thank you both for that. I can see that you've popped on there. Are there any questions for Sola and Irina? I think I echo what has been said in the chat. That was such a powerful video, and I'm sure it's been very well accepted when you've presented it.
It's actually quite interesting because when we presented, there was equality diversity launch strategy at King's, and we presented there, and there was over 100 clinicians. I think there was a minute of silence before somebody could say something about that video, and one of the lead clinicians said that I'm sure none of us come to work to do this or to make somebody feel like that. How did we end up with these stories? Because he said that I'm sure all of you agree that this happens, this is not isolated, and therefore it is really a moment of reflection for all of us to step back and think how we communicate, how we come across, and why our patients feel that we treat them the way they describing.
I completely agree. Fungi has asked, would you be happy to share the video, please?
So whole video is 8 minutes long. Yes, it's almost finished to be created and built, and we have license agreement. It will be free, but we have to license to Kings. Yes, and all what you will need is to send the request to ourselves, me and Sola, and we send you a template license, we sign, and then you will be able to have a film. Absolutely. So for Kings, it will be used for communication training, customer training, and for ADI. And obviously that is what we will be licensing film to be used for.
And I should say that in the slide deck, we have taken out the film because of this licensing agreement that we circulated. But Sola, Irina, are you happy for an email address to be inserted in its place so that you can contact you directly?
Yes,
or the
absolutely.
team?
Absolutely. No problem. Thank you.